Hiya, I'm Hannah Grundy, one of the SSM students on laparoscopic and robotic surgery. And I'm going to talk today about a laparoscopic cholecystectomy. So what we're going to cover today, we're going to understand the anatomy of the gallbladder, learn about the port placement for a laparoscopic cholecystectomy, and also to understand the various steps of one, and then know some of the post-op complications as well. So a little bit about the anatomy. So the function of the gallbladder is to store bile. There are three parts: the fundus, the body, and the neck. The fundus is at the top, the body is in the middle, and then the neck's what connects to the ducts. The vasculature, so it is supplied by the cystic artery and it's drained by the cystic veins. As you can see in this photo, there are the three ducts. So the hepatic duct comes from the liver. The cystic duct comes out of the gallbladder, and then where those two meet is the common bile duct. So a little bit of overview about the cholecystectomy. It's a minimally invasive surgery to remove the gallbladder. It's mostly done due to gallstones. The patient is lying down in a supine position. General anaesthetic is used, and the recovery time can vary, but most of the time the patient either goes home on the same day or only spends a singular night in hospital. So the port placement. First, an incision is made in the umbilicus, and then carbon dioxide is pumped into the abdomen to obtain pneumoperitoneum. And this is to give the surgeons a better view and a bit more space to work. So you put the biggest port, the 10mm periumbilical port, then the other 3 or 5mm ports, one at the right lateral subcostal position, another one at the right subcostal midclavicular line, and then an epigastric port as well. So the first step is the dissection of the hepatocystic triangle. So the gallbladder is retracted over the liver towards the head, and then the neck is retracted inferiorly and laterally. If there are any adhesions, these are taken down using a monopolar energy device. And then the peritoneum is cut along the edge of the gallbladder on both sides to open up the hepatocystic triangle, which you can see in the photo. So next is establishing the critical view of safety. So there are 3 criteria for this. This is a really important view of safety, and it's because there are variations in the anatomy from person to person. So keeping these structures in view minimises the risk of injury. So the 3 criteria for this view is the hepatocystic triangle cleared of all fat and fibrous tissue, and the common bile duct and hepatic duct are also looked for but not exposed. Lower 1/3 of the gallbladder is also separated from the liver to expose the cystic plate, which is the bed of the gallbladder in the liver. And then only 2 structures should be seen entering the gallbladder, and that's the cystic duct and artery. Then the next step, cystic artery and duct is clipped and divided. So 8mm clips are used on the cystic artery. 2 clips are put on the proximal side and then 1 on the distal side. Then the scissors are used to divide the artery. It's the same principle for the duct. Again, 2 clips are on the stay side and then 1 is on the gallbladder specimen side. And then again, the scissors are used to cut them. So at the end, it should look like what it is in this photo. So next step, the gallbladder is separated from the liver bed. This is done using a monopolar energy device. The gallbladder is dissected from the liver bed, and it's really important to stay in the plane between the two. Firstly, because these planes are mostly avascular, so there won't be much bleeding, and you need to make sure that you're not puncturing the gallbladder itself. Otherwise, you might get a spillage of bile or stones coming out. If that does happen, you just need to remove these from the surgical field and clean it out. Retraction and moving the neck of the gallbladder back and forth will give you better visualization to make the dissection easier as well. So removing the gallbladder, once it's completely off everything, off the liver bed, you need to check for any bleeding, cauterize any bleeds using the energy device, and then irrigate the liver bed and aspirate any fluids. And then the bag in the photo is what you're going to place the gallbladder into. It's called an entrapment bag. And then it's removed from the biggest port, which is the 10mm port in the umbilicus. And then all ports can be vented out as well. So closing the port sites, you're nearly done now. So the fascia at the extraction port site should be closed with 0 vicryl, and then the skin closed with absorbable monofilament subcuticular suture. So a little bit about the post-op complications now that you've completed it. So you've got the classic ones that you have for most operations: infection, bleeding, complications of anesthesia. But you can injure nearby organs, and you can get bile leakage, like I mentioned, into the field, but as long as you take that out. So just to summarize quickly, there are 3 different parts of the gallbladder, and it's applied by the cystic artery and it's drained by the cystic veins. 4 ports are required, one of them being the big one that you can take the gallbladder out of. There are 6 steps to the operation that are listed here. I'm not going to go through them again. And that's everything. Thank you very much for listening. I hope you found it helpful.